It's my pleasure tonight to present Dr. Singh as our speaker. Dr. Singh began her training in pulmonary critical care and sleep medicine at the Baylor College of Medicine. She joined the Michael E. DeBakey VA Sleep Center in 2013. Since then, she has really innovated in the field of sleep medicine. She's worked with the hypoglossal nerve stimulators, the Remedy device, and she's also the program director for the Sleep Medicine Fellowship at the VA. It is my pleasure today to welcome Dr. Singh.
Thank you so much. Good evening, everyone. My talk today is about advancements and the potential of drug-induced sleep endoscopy, or DISE, in obstructive sleep apnea. I have no disclosures. Our objectives today is to recognize the principles and procedures that are involved in the drug-induced sleep endoscopy, explain the various clinical scenarios where a DISE is beneficial, including guidance on appropriate patient selection, analyze the implications of DISE findings on treatment choices, be it surgical or non-surgical, and evaluate the recent studies and evidence regarding the outcomes of DISE in managing obstructive sleep apnea.
Dr. Singh, I hate to interrupt. Can you just share your screen briefly here so we can also see?
Oh, yes, absolutely.
Thank you.
And I thought with the webcam on, my screen was being shared.
Sure, I can help you.
Oh, no, there you go. I see the pop-up that I never clicked on. You can see it, right?
Yes, we can.
Perfect, perfect. Sorry about that. All right, so obstructive sleep apnea, you may know, is a recurrent collapse of the upper airway during sleep, resulting in nocturnal hypoxemia, sleep fragmentation, early morning headaches, and fatigue during the day. Certainly, obesity is one of the most common modifiable risk factors, but anatomy of the upper airway plays a big role as well. It could be a deviated nasal septum, turbinate hypertrophy. It could be a long, elongated soft palate. The uvula could be floppy. The tongue could be enlarged, especially the base of the tongue. And then definitely the epiglottis could be floppy as well. And these factors play a big role in worsening sleep apnea. The worldwide prevalence of sleep apnea is quite high, but the biggest problem is that most of it is undiagnosed. You would be surprised to know that the biggest bulk of sleep apnea is actually in the Asian countries. I'm sure the population, especially in China and India, plays a role, but regardless, it's the anatomy and not the obesity that plays a big role. When we talk about the phenotypic characteristics of patients with OSA, we are looking at the male gender, age more than 50, obesity, increased neck and waist circumference, and then the craniofacial deformities. Usually to the prime care, we always suggest to look at the screening criteria, which is the STOP BANG, where each of these alphabets is allotted a score of 1. So anytime the score is 3 or more, it is recommended that these patients should have a sleep study. So once again, the symptoms are snoring, tiredness or daytime fatigue and sleepiness, observed apneas, high blood pressure, BMI more than 35, age more than 50, neck circumference in men more than 16, and then the male gender. The reason we are always harping about treating obstructive sleep apnea is because of the Sleep Heart Health study, which actually looked at close to 7,000 patients, and it investigated the impact of OSA and other sleep-related disorders in being a risk factor for cardiovascular-related mortality. It found that it not only increased the cardiovascular-related mortality, but an increased all-cause mortality. And as the severity of OSA increased, so did the mortality. This was another landmark article in Lancet. And in this, they looked at normal controls, so normal healthy males, compared it to snorers, folks with mild sleep apnea, then those with severe sleep apnea, and finally, adequate treatment with CPAP. It was found that in patients with severe OSA, the risk of fatal as well as non-fatal cardiovascular events was much higher, and this risk significantly decreased once it was treated with a CPAP. So these are some of the reasons why we are always big on trying to treat obstructive sleep apnea, and this is where the therapies come in. Back in the days, it used to be a tracheostomy, just bypass the upper airway and that's that. But of course, recently, the positive airway pressure, be it CPAP, BiPAP, or some of the common modalities. We also believe in utilizing positional therapy, especially in young males, where it's usually supine OSA that we notice. The mandibular assist device, which is like an oral appliance, which moves the mandible and hence the tongue forward. And then there are several surgical options. You may have heard of the UPPP, which is your uvulopalato-pharyngoplasty. It used to be used in the past, but never as a single mode of treatment anymore. The new kids on the block are definitely the hypoglossal nerve therapy, be it a unilateral or a bilateral stimulator. The names of these companies are Inspire and Genio, and certainly these are the new kits that are being utilized to treat OSA. When we look at benchmark for effectiveness of OSA treatment, especially surgical interventions, we look at this criteria, and the aim is to reduce the total AHI, which is the apnea-hypopnea index, by 50% of the total events. And then the total AHI should become 20 or less events per hour. This is how the DISE came into place. The thought was that if real time we can visualize which area of the upper airway is collapsing, hopefully the surgical outcomes will be improved. So DISE came into play around 1990s. It's an exam during simulated sleep that allows us to real time examine the upper airway and figure out that when apnea happens, which is the area that is collapsing. Based on this precise evaluation, our hope is that the surgical outcomes can be improved as well. One has to keep in mind this is just a complementary exam and it does not replace a polysomnography. So some of the indications are definitely back in the day to evaluate for surgical options of treating sleep apnea. Many a times, patients failed these surgical therapies. As a result, we had to go back in, do another DISE to figure out which areas were no longer working. In today's day and age, we definitely utilize it for non-CPAP treatment, be it an oral appliance or the hypoglossal nerve therapy. And then there are certain patients who require very high pressures on their CPAP. So there's intolerance or failure. This is where we utilize the DISE. We go in real time, figure out that with the CPAP running, which area is not moving. There are certain contraindications in doing a DISE. Definitely morbid obesity plays a role just because these patients have a difficult airway. And when we give them the sedation, we don't have a control over the airway. We don't have an ET tube inside. And that's the reason these patients can be difficult to handle. Also, in patients who have severe reflux, once they are given sedation, there is no control on their upper airway, and these patients are at a higher risk of side effects from the DISE. The way this procedure is done, it's an outpatient procedure. We typically use propofol for sedation because propofol is a quick on and off where it induces sleep rapidly. We use a target control infusion, so we use a drip. And the bispectral index, or the BIS, is what we use for the depth of sleep as well as sedation. So it is the poor man's EEG, basically. That's why we utilize it. And the aim is to have a range between 50 to 60. Normally, when we are awake, our BIS will be 90 and above. So we are aiming for some sort of sleepiness where the BIS will be between 50 to 60. And alongside that, we are definitely monitoring their blood pressure, their saturation. We are ready in case there is a respiratory failure. We have our nasal trumpet, our oral airway, and the ET tube ready as well. As a pulmonologist, we tend to use a bronchoscope and not a laryngoscope because many of our patients tend to have COPD or other respiratory issues where we need to suction the airway. And that's the reason a bronchoscope is more handy, unlike a laryngoscopy, which doesn't have a suction channel. When we do the DISE, we are evaluating not only for surgical therapies, but also for other therapies that I spoke about in the past or previously. So during this evaluation, we evaluate the upper airway by placing the patient in the supine position. Then we turn them sideways just to see if supine obstructive sleep apnea can be treated by that. We also do a jaw lift, which tells us if an oral appliance or the hypoglossal nerve therapy will be helpful. And then at the end, we utilize the PAP, the CPAP that they had been prescribed in the past. We utilize a special mask for that. And it tells us that which area in the upper airway is not opening. There are cases where a patient has had the hypoglossal nerve therapy and their repeat study showed minimal improvement in the sleep apnea index or the AHI. And in these cases, we turned on the hypoglossal nerve stimulator. We did a DISE real time, once again to see which areas were not opening. So this is how we do it. We use our bronchoscope. We enter through the nose. We examine certain areas, and that area is defined as the vote, which is V for velum, which is the soft palate, the oropharynx, the tongue, and the epiglottis. If you look at these pictures, unlike a bronchoscopy where we are standing behind the patient, this is done from the front. So when I enter, this is the posterior pharyngeal wall, and this area is the soft palate, and this is called the circumferential collapse of the soft palate. If you look at this picture, the side walls are coming together, so it's a lateral pharyngeal wall collapse. This is the base of the tongue, the epiglottis, and in this case, the epiglottis is floppy, that it's just automatically closing the laryngeal inlet. This is how we do the last part of the study, where we utilize the CPAP with the special mask. So we utilize the pressure that the patient had been prescribed in the past. And in this scenario, you can see that as we go in, posterior pharyngeal wall, this is the soft palate, it's completely collapsed. This is called an anterior posterior complete collapse. We had to do a jaw lift. As a result, the oropharyngeal area did open up significantly. And once we let go and just had the CPAP running, basically there was no opening at all. As a result, the patient was desaturating, and this is because of the apnea happening in real time. So the typical DISE findings that we are looking at, once again, are the vote, which is velum, oropharynx, tongue base, and epiglottis. Simultaneously, we're looking for the tonsils and the lateral pharyngeal wall collapse as well. We define it on the basis of the obstruction that we see. So 0 is no obstruction, 1 is partial, and then 2 is complete obstruction. We also like to know that what is the configuration of the collapse? Is it anterior posterior, or is it circumferential concentric, or is it a lateral collapse? Till now, there is no consensus as to how should we define these findings. So besides the vote criteria, there is a newer system which looks at, once again, the velum or the soft palate, the tonsils. You'll be amazed how many adults still continue to have tonsils. We look at the lateral pharyngeal wall, the tongue base, and the epiglottis. Just because the vote sounds fancier, this is what we have mostly stuck with. But once again, there is no universal consensus. And in addition to that, there is a lot of inter-operator variability. So these are some more pictures that I wanted to share with you. So once again, posterior pharyngeal wall, soft palate, you can see the epiglottis and the base of the tongue. And this is what's called an AP collapse of the soft palate, which is complete. In this picture, you can see that it's just the lateral walls that are coming together. And this is the posterior pharyngeal wall. And in this picture, if you see, the lateral walls are coming together, but so are the anterior posterior. And this is what we call as a concentric circumferential collapse. Some more pictures. Once again, this area with the help of a jaw thrust can be opened. These are the tonsils. And usually the size of these tonsils is small, but just because the upper airway is collapsing, these tonsils do contribute to the overall collapse. In this picture, you can see that the lateral walls are coming together. As a result, the epiglottis is kind of squished between them, and that's how the apnea happens. In this case, this is the tongue base. We have to wait for the apnea to happen. So snoring and apnea is what we are waiting for when we do a DISE with sedation. And this is where the apnea happened. And the reason is that the tongue base went towards the posterior pharyngeal wall and closed off the epiglottis. These are some more pictures where this is what a normal scenario would be, where the airway is open, the laryngeal inlet can be visualized. In this case, for no reason, because the base of the tongue is not impinging on the epiglottis, but regardless, the epiglottis has closed up, and hence the patient is having apneic events. This is what we call as a floppy epiglottis. So normally when we are eating, our epiglottis closes our laryngeal inlet, but in these cases, because of a big negative inspiratory pressure, so basically because of the OSA, the epiglottis is floppy and it closes the airway. This is another picture where the epiglottis is called omega shaped. This is just the anatomy per se. And as long as the inlet is open, we are okay. But as the collapse worsens, chances are that this inlet will close up and cause hypoxemia and apnea. This is a case where the patient had a hypoglossal nerve stimulator. And in this picture, this is an AP collapse of the soft palate, and then the base of tongue is completely collapsing with no view of the vocal cords. Once the therapy was turned on, as you can see, the airway has opened up nicely, posterior pharyngeal wall, soft palate. And then this is the oropharyngeal area where you can see that the base of the tongue is no longer obstructing the laryngeal inlet. These are some more interesting pictures that we found in our patients. So in this case, the patient was complaining of difficulty tolerating his CPAP. His pressures were quite decent, 15 centimeters of water. And as you can see, the reason he felt that he was claustrophobic is because the airway was continuously closed. That CPAP of 15 was not doing anything, hence the symptoms. This is another picture where the CPAP was running and the patient complained of difficulty tolerating the nasal mask. And one of the reasons was that he had a septal deviation of the nose, he had a spur, the turbinates were hypertrophied. But along with that, the soft palate was completely collapsed. It was barely making a difference. Some more interesting pictures. Again, the lateral collapse, the CPAP is not doing anything. The AP collapse of the soft palate continues. And here, so keep in mind that when we are doing this procedure, when there is a complete apnea and the airway shuts down, I don't have a view. But when we are able to get a view, this is what we sometimes find, that the tongue is coming together, squishing the epiglottis, and hence the hypoxemia happens. And once again, the CPAP is not able to help these patients. So the point being that when patients come and complain to us that, hey, I can't tolerate my CPAP, it's not always in their head. It's actually a real, genuine problem that we come across. Once again, another patient where we had a circumferential collapse. We couldn't do much about this, so we sent him to ENT. He got the UPPP. As a result, the collapse changed into an AP collapse, and this is the time we can offer them alternative therapy like the hypoglossal nerve stimulator, because typically it is contraindicated in patients who have a circumferential collapse. But if we can convert the collapse into an AP collapse, then we can certainly offer them alternative therapies. This case, in this patient, we really had no collapse of the soft palate or the base of the tongue, but the interesting finding was the epiglottis, that it was completely retroverted, it was completely collapsed on itself, and as a result, the vocal cords were completely blocked, and this is the reason the patient had a severe OSA. So it was a simple fix where we were able to open the epiglottis and fix the OSA. So it's quite amazing what we may actually see. And again, the point being that the DISE does help us in figuring out which area may be collapsing, but it really doesn't impact the long-term outcomes. The reason being that sometimes it's just not a single level collapse. It could be a collapse at multiple levels. For example, in this patient, once again, a circumferential collapse of the soft palate. The base of the tongue, as you can see, is squishing the epiglottis. He got the UPPP, converted into AP collapse. We got him a CPAP. And really, once again, the CPAP did not do much. And in this picture, we did a jaw thrust. There's something else that we call the hyoid pull. We did all of that. And you can see that the airway did open up significantly. So once again, the clinical significance of DISE is that we are able to figure out where exactly the collapse is. So there's always a primary site of collapse, but based on the secondary site of collapse, the surgery may or may not be successful. Many a times when we send these patients for a UPPP, they come back. Once the swelling has decreased, we repeat a sleep study, and oftentimes the apnea-hypopnea index continues to be quite high. There are certain scenarios that we see on a DISE, which does tell us that chances are that the surgery will not be very successful. And those cases are where the soft palate has a complete circumferential collapse, or the base of the tongue has a complete anterior posterior collapse, or the lateral walls come together and squish the epiglottis. There have been several advancements in doing a DISE. So once again, DISE and the description of the vote criteria is completely inter-rater dependent. So subjectivity plays a big role, and as a result of that, there has been a push towards doing a pharyngeal manometry to kind of objectively assess how bad the upper airway collapses. So real time when we do a DISE, we are able to pass a tube which has pressure sensors, and we place it in the pharynx or towards the upper esophageal sphincter, and we are able to assess how bad the collapse is expected to be. So higher the pharyngeal opening pressures and higher the pharyngeal critical pressures, it indicates the collapsibility will be very high. And as a result, we are expecting that the surgery will not be very successful. And at the very onset, we are thinking of multi-modality therapy. We also know that just because these pressures were so high, these patients will end up requiring high CPAP pressures, which again will be difficult to tolerate. So we start planning, we start thinking of multimodality therapy, be it a CPAP with a hypoglossal nerve stimulator or other options. Back in the days, the choice of sedation used to be Versed or midazolam, but it was found that it resulted in a lot of false collapse of the upper airway. Additionally, it took a long time to recover, and patients who have OSA, just because it is an outpatient procedure, we would want them to be discharged by mid-afternoon, and with midazolam, that was a problem. So our go-to medications are typically propofol and Presidex, and propofol is what we prefer because, as you know, Presidex kind of doesn't have an impact on the respiratory or the upper airway. Things don't collapse. So basically, falsely, things are not collapsing. We really can't figure out if there is collapse or not. Hence, propofol is what we use. Once again, it's a target control infusion. And we do not do bolus because, once again, we do not want things to be falsely collapsing. So the bottom line is that back in the days, DISE was just used for planning of a traditional upper airway surgery. But since then, the precision medicine and OSA management is what a DISE is utilized for. So we can PAP optimization, so real time, we can use a CPAP, we can titrate the CPAP, we can figure out why someone cannot tolerate a CPAP based on what area is not opening. Based on the DISE, we can figure out if an oral appliance will be an option for the patient. If there is no circumferential collapse of the soft palate, we can offer the patient the hypoglossal nerve stimulator. And if sleeping on the side improves their collapse, then we know that positional therapy can be offered to this patient. So the bottom line in conclusion is that DISE does influence treatment selection based on site and pattern of collapse. It also helps us in promoting precision medicine. We can troubleshoot PAP failure and evaluate alternatives. It does have limited predictive value for surgical outcomes, and the reason being that it's never a single level collapse. Oftentimes it's a multi-level collapse, as we saw. The soft palate, the tongue base, the epiglottis, all could be the culprit sites. And ultimately, how much will the apnea-hypopnea index will reduce is based on the kind of collapse and what options for therapy do we provide these patients. And that's all. can take questions if someone has any.
Yes, Dr. Ahmad?
Thank you, Dr. Singh. That was great. Can you hear me?
Yes, I can.
Okay, great. I do have a few questions. First of all, that was an excellent talk.
Thank you.
I personally learned a lot, and definitely a therapy that I'm not that experienced with. So definitely something that I can see recommending to my patients, are actually sending someone to sleep medicine for better evaluation. One of the things that one of the audience members asked was, you mentioned how DISE is used for planning of upper airway surgery, for PAP optimization, for oral appliance use or hypoglossal nerve stimulator placement. When do you decide that, hey, this is a patient that will need an evaluation by DISE? Is it when you have an initial sleep study done and you see that they have severe sleep apnea, or are you seeing them after they have not tolerated positive pressure therapy and are coming in with non-compliance or poor response to therapy?
Absolutely. So the current guidelines for giving someone alternative therapy, especially hypoglossal nerve stimulator, is that they should have failed PAP therapy. So ideally, they should have utilized it for 3 months. And if they can't tolerate it, that's the time they come back to us and we are ready to evaluate them with the DISE. However, there are certain patients who will tell you at the very onset that there is no way that they would utilize a CPAP or utilize the mask. In that scenario, especially if their AHI is in the severe range, we don't wait. We go ahead and proceed with the DISE and start looking at alternative therapies rather than waiting for those 3 months, given the significant morbidity associated with untreated OSA.
That's great. I think that definitely makes sense. And I do have some patients who have had non-compliance with CPAP, so I can definitely envision those patients benefiting from this. Another question that I saw in from one of the audience was just a question about the targeting of sedation. Is it just based on the BIS, you always keep them in the 60 range, or do you ever go deeper if you're not seeing collapse? Like, is the goal of sedation to obtain collapse, or is the goal of sedation to reach that BIS and then just monitor?
So that's a great question. So patients are different. I've had older or younger patients completely out at a BIS of 80. And I've had some patients at a BIS of 40, still fighting, still talking. So that is a rough indication. What I'm actually looking for is some degree of sleepiness where they are not responding to commands. They are not overly sedated, which means that I'm evaluating the airway real time to make sure that nothing has, if everything has collapsed, it means it's sedation induced. So I'm looking for snoring, because typically snoring does happen when they are in a lighter stage of sleep. So that's one thing that I'm looking for. Additionally, the anesthesia team is there. So real time, I can see how much of inspiration, expiration they're having. And if the patient is completely apneic and continues to be apneic, is the time I will back off on my sedation and give them a chance to kind of start snoring and start breathing, because I would want them to breathe so that I can look for those apnea events to happen. So yeah, great question. It just is completely dependent on the patient and his history of substance use in the past. And I would say look for snoring, make sure that the patient is still breathing and not completely apneic.
Got it, got it. No, that's very helpful, because I was also struggling with that concept. Yeah. One of the questions, another question that I saw was, do you ever have an issue with just inability to really rescue the patient once you have placed them under sedation? Do you ever have issues with having to maintain a patient on a ventilator to kind of get them through the day, especially with these sleep apnea patients? Oftentimes it gets a long amount of time for them to be fully awake. How do you?
Sure. Yeah, so, thankfully, so I have done around 350 DISEs, and there was only one patient who was a young gentleman whose AHI was 120 events per hour. And the only reason I decided to pursue the DISE was given the severity and his young age. And that was the only time, that was amongst my first couple of cases, that he did stop breathing. And the advantage with propofol is that it quickly gets out of the system. So while we were waiting for the propofol to get out of the system. We just put in a nasal trumpet. We had the patient's head raised up a little bit, and that's it. Within a few minutes, the patient woke up. So thankfully, we have never had to intubate a patient, never had to put them on a ventilator. And that's the advantage of propofol, which will not be the case with other sedatives. So hence the use of propofol.
One of the other questions I'm seeing in the chat is about the type of the scope. Obviously, you're going through the nasopharynx. So are you using a diagnostic scope? Are you using an ultra-thin scope? What scope are you actually reaching?
So I definitely keep the PD scope ready, but the suction channel is not the best. So typically inner diameter of 2.1 is what I utilize, and I think the outer diameter is 2.4. You don't want the scope to be too thick because once again, you're entering through the nose, and you don't really want to block the airway too much. And that's some of the reasons that we don't even spray lidocaine or anything else to keep the airway as it is in a normal situation when the patient sleeps. So yeah, typically 2.1 inner diameter should be sufficient to give you enough suctioning and still give you a clear view of what you want to see.
Great. I think one of the last questions I see here is people did want to get some more insight about the dosing of the anesthesia. Is it, I think you did mention that you do, usually you would prefer propofol over Precedex, but can you just speak more on that?
Sure. So typically 25 is what we start with, 25 micrograms. Unless and until I see that the patient has a history of substance or drug abuse, then we typically start at 50. We typically wait for 5 minutes, and if we see that the BIS is not dropping, then we go ahead and just up it to 75, 100. So it's completely dependent on how the patient is responding. But that's where the BIS really helps, because if the patient is getting sedated very well, the BIS will start coming down quite rapidly, and within no time you will be down from 90 to easily 50 or 60. So yeah, typically 25 micrograms is a good place to start. The anesthesia team should be there monitoring all of that, because you won't have the time to watch the patient as well as kind of manipulate or control the sedation as well. But yeah, typically just a drip is what's running, and I'm continuously looking at the BIS.
Another question here, I think now they're coming in fast and furious. So do you keep the videos stored, or do you just share them with ENT, or do you have these static images that you share with ENT when they're planning surgery for these
Great
patients?
question. Great question. So I do both. For the first 100 patients, definitely I kept their video recordings in our bronch suite, and the pictures, the static images, are what's on the bronch report, and that's what goes to our ENT, who then sees it and plans the surgery or whatever we have recommended. And yeah, basically videos are a good thing to have, just so you can go back and see what exactly was the area that was collapsing, because sometimes in a day we would do as many as 10 cases and things kind of get mixed up. So yeah, that's where the videos help us, but the reports are pretty good, that they will have the images, they will tell exactly where the collapse was and what should be done for that collapse.
I guess on the same line, just speaking with collaborating across specialties, like what challenges did you have working with anesthesia or ENT to kind of have them kind of accept what you are doing and how you're approaching these patients?
That's, again, a very good question. So I've heard, when I've met other colleagues in POM critical care, I've heard that it can be quite a challenge working with anesthesia and ENT. Sometimes ENT wants to do it their own scope. Certainly the advantage is that as pulmonary, we do have a better idea with our bronchoscope, and we certainly take the time as well to evaluate the upper airway. With all due respect to ENT, when ENT does it, it's a little bit more rapid, and ultimately it will be you as the sleep physician who will be managing this patient once they get whatever treatment they get. If the apnea index is not controlled, it'll be you dealing with those challenges. So evaluating everything from the very onset certainly gives me a better idea what I'm dealing with, because oftentimes you can fix the apnea, but the snoring still continues. And to the bed partner, that's the bigger issue. So if I know that, okay, this patient had deviated septum, this is something else that was going on, then I know that if snoring still continues, that's the area I would focus on next. I was fortunate that in our area, we have a very robust interventional pulmonary program as well. And as a result of that, our bronch suite is very well established, and anesthesia is always there on certain days to help us out with our EVIS or rigid scopes. So it was quite easy to just pick up a day in a month and have all my patients come in that day and just do 10 cases in a month and be done with it. So I think it certainly depends on your anesthesia and ENT team, but actually you are doing ENT a favor because you are the one dealing with the patient in the clinic. You know nothing is working and you've tried everything. You're the one who decides that, okay, the patient meets criteria, so let's go ahead and do the DISE, see what the findings are, send them to ENT, ENT does what it's supposed to, and then again, you do the follow-up. So yeah, you have a better control on everything just because you're managing everything.
That's great, and that's really encouraging to hear that, you know, working across disciplines, we can really take care of the patients much better.
Yes.
That's all we have for today. I don't have any other questions, so I just wanted to thank you for your time and your expertise, and I know myself and our audience learned a lot, so thank you again.
Thank you so much. Take care.
Yes.
Bye-bye.
Thank you. Have a good evening, everyone.